I'm Carolyn Lowell, the Chief Content Officer at OrthoWorld. I oversee OrthoWorld content and Bone Zone, as well as the education here at Omtech. Joining me is Dr. Sharat Kusuma, who is the Chief Strategy Officer and Chief Medical Officer at ExactTech. Before joining ExactTech, he worked at Apple, and he is also a trained hip and knee surgeon. And then my colleague Mike Evers is our Senior Market Analyst at OrthoWorld, and he covers the enabling technology market, does a lot of analysis, speaking to CEOs on this topic, and has essentially come up with where he thinks the numbers are and the size of this market. So we're going to do a little bit of a short presentation with each of them, and then we're going to go into a Q&A. Just to show of hands, I guess, before we get started, to get an understanding of where people's knowledge is or experience is with robotics. Does anybody in this room work for a company that has a robotic system? One, okay. What about surgical navigation or planning? Yeah, okay. Navigated instruments? Okay, and is anybody in here a contract manufacturer? I know there's many contract manufacturers here at Omtech are helping make the components. Okay, well that's helpful, thank you. So I'm gonna hand it over to Mike to start the conversation.
Thanks, Carolyn. So everyone, I'm just gonna give a very brief overview of some of the data we've collected about this portion of the orthopedic market. And I think maybe despite some of the hype and so much attention provided on these topics during earnings calls, is that it really is, at this time, a tiny slice of the orthopedic market. We're figuring about 2.3% of the 59 billion orthopedic market. Now, that is only including sales of capital systems, disposables, and service, things like that. But as you can see, it's really a relatively small number of companies that have robotic systems. I think the core of this part of the market is really in the software side, surgical planning, surgical navigation. And I think that's where ultimately we're going to see a lot of the innovation and the products and the platforms that ultimately drive adoption. I know Sharat will talk about some of the barriers to adoption in the robotic systems in his piece. We have a lot of familiar faces at the top of this point in the market. Stryker, given their long history with Mako and cementless knees at the top there. Globus, really by virtue of their merger with NuVasive. In our data, we consider NuVasive's neuromonitoring products to be enabling technology, but then everyone else, the players that you would expect. But I do think really that the idea of these companies driving capital sales and robotic sales sort of went by the wayside in the aftermath of COVID, where we saw a lot of focus being placed more on placement than outright sale. Companies are really trying to drive the robotic procedure now as a way to defend their existing market share. These are closed systems, obviously. If you buy a Stryker robot, you must use a Stryker implant. So it really gives them a great way to moat off their high margin implant share. And as you can see, this is based on Wells Fargo data that's a couple years old, and then we've extrapolated it out. But really the push, whether it's by rental, lease agreement, or sale, to get robots into the marketplace. And then I thought this was interesting, and I really wanted to include this slide because Sharat and I have been talking in our keynote preparation, and one of the themes that has come up is sort of this shift in power balance away from the surgeon. So when I heard Globus Medical talk about what they call their virtuous cycle, the cycle that allows them to keep building and growing at the pace they were before the merger, you can see that surgeon evangelist piece right there is a really important part of their virtuous cycle. And I'm curious to see how that's going to play out in 3 or 5 years as the power dynamics continue to shift between surgeons, administrators, and hospitals. And then recently, in their most recent earnings, Medtronic CEO Jeffrey Martha had a quote that really caught my attention. Now, I want to be clear in this, he was talking about ABLE, their cranial and spine ecosystem of enabling technologies, so different than ortho. But he said that accounts or hospitals are making investments in a company now, that the Medtronic ecosystem versus some other full-fledged ecosystem. And that dynamic is changing the very structure of the spine market. Because I think it might have been a year ago to the minute or hour that I sat up here with Kevin McGann from Excellis, a smaller spine company, who had just sold their spine robot Remy to ATEC. And one of the reasons he said was it was so burdensome on a spinal implant company to gather all this new expertise, to stand up a capital sales force, that it really knocked them off of their path. And then they ended up selling their robot. So I think Mr. Martha's comments here kind of resonate in the spine market. But then at the very end there, he says, because of this, you won't have this long tail of tiny spine companies preying on docs. Those companies are going away. Now, Sharad, I know you'll have some opinions on this, but just to see it so clearly stated like that caught my attention. But then there are, as we showed in that slide, where there's in the middle, a lot of these software companies and smaller companies are really where the innovation is coming in this space. And right now, at least from the companies I've surveyed and spoken to, they're highly focused on driving value. So you have Innovis with Arvis, the augmented reality navigation system, being a more cost-effective, ASC-friendly solution. If you talk about Ortholine and their sort of disposable lantern, they talk often about the dubious economics of having a full-fledged robotic system in every OR. DirectSync and Carlsmed are really trying, through enabling technology, through software, to take some of the $6 billion in excess cost out of failed spinal fusions. Think Surgical, who was just in the news because of their partnership with Zimmer Biomet. Their T-Mini system is an open platform, which I think personally excites me. I think there's a point where that should be the standard, but I think they have a long road, and that model has a long road to go to gain acceptance. And then we see, traditionally it's been robotics in spine and joint replacement. We're starting to see some more indications come out and be approved, whether it's in soft tissue or the shoulder now. So that's sort of my rapid fire sum up of the enabling technology market. I'll pass it over to Sharad.
Thanks, and I'll stand if that's okay, because I'm
Sure.
kind of used to standing. So just a little bit of background. Again, Carolyn, sorry you had to trade down from Dr. Polstra to have me give the talk, but I will say, you know, this whole, I practiced, I'll just give you a little bit of a history. I trained actually at Rush here in Chicago, just down the street from where we're standing now. And in I'm a hip and knee surgeon. That's kind of my original, my love and my DNA. And during my career, my clinical career, which admittedly wasn't 5 decades, but you know, I think I had enough time to gain the T-shirt. I did make a conscious effort to use a lot of different technologies. I don't know, maybe because I just enjoy it. So, I mean, I've been thinking about this space for a long time. And just give you some context, I finished my fellowship in 2009. So what is that, 15 years ago, I guess. And so I got to see sort of this, surge of technologies. And so, and as Carolyn mentioned, I didn't have a month to put this talk together, but it may feel a bit schizophrenic, but hopefully in the schizophrenia, you'll see some of the themes that are sort of relevant that I think that bring together the sort of what the surgeons are thinking about, what the patients are thinking about, what the companies are thinking about, and then, you know, we can maybe have a good discussion. But so, I mean, I can tell you this. Whoop, sorry, I went backward. So I can say this. When I was first in practice, right, as a doc, when you're a young, and I'm not young anymore, but when I was young back then, and you're in a new city, and I just for some context, I practiced in Columbus, Ohio. I believe Columbus has one of the highest densities of orthopedic surgeons per capita of any. I believe that's probably roughly, because it's a cool place, you know, pretty good place to live, you know, decent cost of living, right? And there's some big universities. So, you know, when you go into a new city as a surgeon, as a new hip and knee surgeon, it is incredibly competitive, right, to hang your shingle and build your practice. So I'd always been thinking about, well, what can I do to, and I promise this story has a theme as we get through this. And if anyone has any questions, obviously, please raise your hand and interrupt. But, when you think as sort of what we as surgeons are looking for, we want to differentiate our practice, right, from the other surgeon down the street who's also doing hips and knees probably quite well. I want to grow my practice, right? We want to grow our practice. And, whether we like to say it or not, building a practice of Medicare-only patients is not the path to some, amazingly financially successful career, because being paid $1,100 a knee replacement, I mean, that's plumbers make more. I mean, and that's not an exaggeration, right? For what we do. And then, in terms of the ASC, as things might, and we can talk a little bit about that. I think if, for those of you who were at the keynote this morning, a lot of us surgeons, and again, I don't practice anymore. I'm in industry fully now, but a lot of my colleagues who are still, kind of slogging away at practice every day, they've moved their site of care from the hospital to the ASC for a multitude of reasons. I'd say the top two are economic and lifestyle, right? And so for them, in an ASC model where they are actually owners of the facility, any technology enabler is going to have to be somewhat cost conscious, right? It's different when I work at a hospital like Rush, where I did my fellowship. I have that large health system to buy the robot for me. When I'm running my own ASC as a small, 3 operating room, ambulatory surgery center, I'm looking at the bottom line. I need to find a system so anyway, just giving you some idea of kind of what we're thinking about. And so if you think about ASC, right, what would be an ideal killer offering? And I've got it on the slide here. Number one, no capital cost, and I want some savings on sterilization. Right? I don't have this giant SPD department downstairs, right? Number one, I can't bring the Optimus Prime transformer. I don't have room for that, right? I need something small, number one. And number two, I want the device to have some clinical benefit, right? It's not clearly just a device that just is there. Now, again, Mark, don't get me wrong, and I'll talk about this. Marketing is indeed important, but I at least want the device, whatever it is, to help me do an operation a little bit better, and I'll show you some pictures later. Number three, I want it to be fast, right? Because in the ASC, I'm the owner. Time is money, right? If I can do more cases, the ASC does better. Again, it has to be small and space efficient, right? It's got to fit in my little operating room. I don't have a corner where I can park the robot. And then finally, I think in terms of, this is something that maybe doesn't get talked about very much. If there's any way think about how things are different when I do surgery in the hospital versus an ASC. In the hospital, I've got a nurse navigator and a physical therapist, and even a whole nursing staff that sees the patient. In the ASC, the patient comes in the morning and they're going home at lunchtime. They don't have any interaction. I would love my system ideally to help me communicate with my patients, right? And so these are things that don't necessarily get talked about very much. And here are a couple other things that don't get talked about very often, right? And this is something that none of the companies will say. I guess I can say this because I am one of them. Being a surgeon doing 8, 10, 12 knees a day is freaking exhausting. I don't care what anybody tells you, it is tiring. And one thing, especially on the right, the cognitive burden of trying to do 12 well-balanced, perfect knees a day is tiring. If the system can help me and here's what I'll say, imagine it's Friday afternoon, I've been working all week, I've got 5 knees or 6 knees, and you're the 6th knee on Friday. You don't want to be that patient, trust me, because I'm tired, the operating room staff is tired. What some of these systems can do, they can lower my cognitive burden of having to make the decisions, right, of having to make the bone cuts. And so, again, we can talk, if you guys we can talk more about that, but that's something that I think. Now, there's one other thing on cognitive burden, right, I talked about earlier. If you think about, again, think about my story. I'm a 33-year-old surgeon fresh into Columbus, Ohio. I need a marketing differentiator, right? Now, I clearly didn't go to business school. I did happen to go to business school, but a lot of my colleagues didn't. I'm not some marketing guru. I love the technology to be a turnkey thing where I can just put it up on my billboard and say, I don't want to have to think about how to market my practice. If the system can help me market my practice, that's whether we like to admit it or not, that's super helpful, right? So again, I think the term, when we talk about robotics, and I'm kind of jumping around a little bit, but what it really accomplished it enabled surgeons to sort of immediately, without having to think about it, without having to hire a marketing person for their practice, they immediately differentiated. You see what I mean? You put the term robotics on your practice, and immediately you're a bit differentiated. Now that's changed now because there's so many robots in every. But anyway, those are some things to consider. As far as patients go, right? I mean, what do patients want? Well, number one, they want to recover quickly and get back to work or their grandkids. I mean, every patient wants this, right? They want less. They're terrified of pain, right? But here's kind of the bottom left is interesting. Every patient wants to be able to tell their friends, their family, and I've lived through this, right? That whatever it is that I had, it was the latest thing. They don't necessarily care what it really was, but they want to be able to articulate to whoever asks them, oh yeah, I went and had that latest technology. That matters to a lot of patients. And then finally, the last thing, they don't want to go into the hospital if they can, right? So if you think about what we'd look for in a robotic or a navigation system, and again, what I've just articulated, what I just laid out a minute ago, that's a high bar. I mean, a system to be able to do all of those things is pretty, pardon my French, pretty damn hard to accomplish. Now, here's an interesting thing here, and AAHKS, I don't know if you guys know, AAHKS is the largest group of hip and knee surgeons in the world. It is the American Association of Hip and Knee Surgeons. We have a meeting every November. I think AAHKS now has somewhere like 5,000. I mean, it's actually become a bigger hip and knee meeting than the AAOS, which used to be right. And so they did a survey, and some of my colleagues actually published this paper, and here's what it says. They talked about why is it that surgeons are adopting robotics. Well, it's interesting. Non-clinical reasons such as marketing, administrative pressure, and even peer pressure, right? The fear of losing my shirt if I don't have a robot on my billboard was the motivator for 20% of users. Well, that's only the people who are honest, right? If you ask how many people, in your clinic who smokes, only half of them raise their hand. So you could easily double this number and probably be correct. You can see that, non-clinical reasons are driving. So, I mean, there are a lot of different elements of what's driving this sort of robotics thing in our, now here's another thing I'll tell you, and I lived through this, right? Our paperwork burden with payers, and I mean, you guys have to be reading about prior authorizations and things. I mean, it is a nightmare, the number of full-time employees we need, and in my former life in our offices, to do this stuff. So again, if the robot or the system is adding if it's adding cognitive burden, that's not a good thing either, right? And again, as you've seen now, back to kind of jumping around to the marketing thing, right? I mean, the number of billboards, that's Philadelphia on the top left there, right? It's interesting, isn't it ironic to see a billboard for the Hospital for Special Surgery in New York City, in Philadelphia? They're trying to get people from Philly to drive to New York. But anyway, my point is, make no mistake, orthopedics is competitive. I mean, obviously it's competitive at the industry level. Stryker and Zimmer are competitive, and all the manufacturers in here compete with each other. But on the clinical level, there is a ton of competition in every city, right, for patients that are commercially insured. And so that also drives a lot of this sort of symbiosis, I guess I'll say, between the implant companies or the purveyors of robotics who are trying to give us, when I say us, the clinicians, tools that help us differentiate ourselves, right? So again, it's interesting to see that. And you can see, right, if you kind of do a search on, the robotic knee surgeons near me, I mean, the number of, first robotic case in Kosciuszko County. I mean, everybody's got a first. I'm the first robotic surgeon in this on this street. But the guy on the next street over to was the first 2 weeks ago. It's amazing how much marketing buzz has been generated by this. And so here's some other, and I'm kind of jumping around a bit. But if you think about, we talked about marketing. What about clinical things, right? Here's some interesting stats from the academy of my colleagues. The real takeaway of this, and we're talking about knee replacements right now, right? Just to give an example. 3/4 of knee replacements in this country are done by relatively low volume surgeons who don't do many knees. And for those of you who came to the keynote this morning, I gave a bit of an impassioned, speech around, I mean, right, America's a huge country geographically. We can't have fellowship trained experts doing knee replacements in every little city. It just is not possible, right? So, I mean, I think if these robotic systems, forget some of the marketing things, forget some of the cognitive burden, put that aside for a minute. If these navigation stroke robotic systems can help every surgeon do a much better knee, that I think is a great, clinical goal. And there is some data, I think, to suggest that the adoption of these systems now can improve those. Now, here's the irony, right? A lot of the smaller hospitals that maybe could benefit the most from these systems, they may not be able to afford, spending $1 million, right? So there's a sort of weird irony that the Rush University of the world that have plenty of dollars, they can buy the robots. They may not need. So anyway, a lot of interesting dynamics. So, and here's another way to look at and this data is about 2 years old, but surgeons who do less than 100 knees a year do almost 75% of the, so again, if you slice basically what we're showing here is in the Pareto diagram, a lot of low volume surgeons are doing a lot of knee replacements. And here's a really interesting slide. When you get below about 50 knees a year, the revision rate almost doubles. You see that? The sweet spot is right here around, and I'm not able to point, but if you can see around 150 knees, the revision rate's down to 1.5%. The person who does, 10, 15, 20 knees, the revision rate is almost 4 times. I mean, that's a staggering difference, right? So again, you could argue that, some of the lower volume surgeons could, and again, there's just another way of slicing the data, right, is that, there's a big opportunity to capture market share, if you can target that lower volume segment. Now, here's another way I like to think a little bit about, this is coming at it from a surgeon and sales force. You talked about capital sales. Teaching implant companies how to sell capital is not easy, right? So, orthopedic sales reps are good at selling implants, and that's what they've been doing for 40 years now. The way I like to think about, if you look at this, what I've drawn here, on the y-axis, I'm calling it sort of how much pain of adoption is there, how long is the learning curve for the surgeon to learn a technology, and how much clinical value is there, right? Well, what you'd like to have is you'd like to have the pain of adoption. You'd like to be in the bottom left quadrant, right? Bottom right quadrant. You'd like to have the technology be super easy to adopt and have a ton of clinical value, right? I mean, if you think about it, that would be the optimal solution. And I would argue a lot of the solutions today, and back to the Apple reference you made, my feeling is that a lot of them don't, there may be actually more in the top left where they may not have a ton of clinical value and they have a steep learning curve, to adopt. So I think there's a ton of opportunity to improve on that. And here's another way to think about sort of, if you think about the surgeon archetypes out there, I've named my colleagues on the left, planners, in the middle, what I'm calling in-betweeners, and on the right, intra-op decision makers, right? And so again, if you think about, just how planners are people that like to use pre-op planning, which is not really robotics, right? Pre-op planning means you get some three-dimensional imaging of the patient and you're trying to make sure you know exactly what you're doing. What I call the in-betweeners are people who like to maybe do a little bit of planning and they like to do intra-op execution. And then finally, the intra-op decision makers, they're people who they don't want to do any planning, they want to get in the OR and just start doing cases. So again, this is another way to think about, what I've done here is I've just put a bunch of different technologies on the graph, and you may not agree with this, but where do these different, different robotics, where do they land? This is sort of another way, I put IntelliJoint on here, I put OrthoSensor on here, I put Mako and, so this is another way to think about the world. I put Conformis on here, right? And so again, these different technology solutions sort of address, and then let me see if I can keep going here. And then as far as the continuum of care, right? There's another way to think about some of these technologies. Do they address the continuum of care before surgery? Do they address the continuum of care like in the, just intraoperatively? Or do they address the continuum of care post-op? And I'd argue a lot of the technologies right now are only focused, on the intraoperative. They're not doing a lot to help us, before the surgery. And so again, I think there's an opportunity here for that. Kind of the last way to think about this that I think is interesting is by anatomy, shoulder, if you think of the major joints. And again, so I'm just giving you sort of ways to think about as you're assessing the space, what unmet need are these things addressing. Now, if you think about, you brought up the example of OrthoAlign. I mean, they're an interesting case study, and Eric Timko, the CEO, is actually a good friend of mine. I think it's amazing what they've done. I would ask you the question, does advanced technology actually equal robotics? You put that slide there about the market share. Well, OrthoAlign in 2023 will do about $50 million. And I mean, that's impressive. They don't sell any implants. They sell disposable navigation units. And the fact that a company can do that, I mean, it shows to me at least that advanced technology does not necessarily equal capital sales. This data is pretty compelling. So I guess what I'm trying to say here, if you segment the market out, there are clearly surgeons who don't believe that they want to have a large capital unit, right? And again, if you think about what Stryker's done, it's interesting, right? And I remember this during my career. In 2008, everything Stryker talked about was the triathlon, the implant. Well, now today, they don't even use those names anymore. Those are sort of flagship. The triathlon knee has been around for, it's sort of a mainstay name in orthopedics. It's gone now. They talk about the Mako knee, right? And so again, it's interesting that at least Stryker as a company has done a pretty darn good job of shifting the attention away from the implant and focusing on the technology. The question is, do others follow? And again, even in terms of what I call evidence-based marketing, they've done a great job of trying to tell a story that yes, there is a clinical benefit. Now, again, there's countervailing literature on the, at any sides of this. But I mean, if you look at, you had a slide similar to this on the pull-through. I totally agree with you that trying to make money in selling enabling technologies is incredibly difficult. But you can clearly see in terms of overall market share, and this data is a little bit out of date, but the companies that have adopted these, have really grown their market. I mean, there's no question that it's returned investor shareholder value because their pull-through sales have been quite staggering. Now, one other topic I think is interesting is image versus imageless. I'll tell you one thing is that as a surgeon that is curious how you guys would think about this. The idea of using a CAT scan to plan for surgery, there's something that feels good about it. You know why it feels good? It feels good because if those of you who've been in the industry for a long time, for the last 40 years, most of us who do hips and knees and shoulders, we've done all our planning looking at a two-dimensional. We just throw the x-ray up there, we take those old school, acetate templates and we lay them on there. Doing a three-dimensional image feels accurate. Whether it actually, that's a separate question, right? But I mean, the point is, I guess, what robotics and what some of these CAT scan-based systems have done, at least I can tell you from me and my colleagues, they made it feel like we're doing a better job of an accurate sizing. And again, the literature is kind of, is now what's interesting, the irony here, right? Most CAT scans don't actually account for the cartilage. So you could argue there may be 2 millimeters of inaccuracy, which ends up being the same accuracy that you have with mechanical instruments. So a lot of irony around here. I'd like to do some clinical studies maybe where you compare navigation systems to robotics. Now, one thing I would argue, navigation software has been around for 30 years, since the late 90s. What I find fascinating is that in the last 15 years, the term robotics has made navigation software cool, but really it's the software doing all the work. It's not necessarily the robotic system that is making the knee more accurate. It's the fact that you're measuring the angles, you're measuring the bone, right? And a lot of systems can do that. So I do find it fascinating that robotics has become such a buzzword when really it's a navigation software that's pretty similar across platforms, right? The software from one company versus another is not really all that different. So, those are kind of the last thing I do want to show you in terms of clinical benefits, right? These are some pictures of a patient and a friend of mine, and and let me make sure I've got be honest. Okay, the top pictures, right? You can see the thigh and their foot. That patient had their knee done, the one knee replacement done with a navigated system. And I don't know if you've been in the operating room for a knee replacement, but what we normally do with mechanical instruments, we make a bone, we put a rod in the femur, we put a rod in the tibia to sort of measure our angles, right? What I'm trying to show the contrast in terms of clinically here, when you do robotic systems or navigation systems, you generally don't need to instrument those bones to cut the bones. Well, look at the difference at post-op. Same patient, a year apart, the bottom knee was done first. Look how much bruising they have in their thigh and their calf and their foot. It's staggering. I mean, their whole look on the top, they hardly have any bruising. This is an interesting dynamic of sort of the difference between the sort of the trauma to the body when you avoid putting those measurement devices that you do with mechanical instruments. So anyway, I thought that'd be interesting to show. Here's an example of this. Sorry, is my video going to work? How do I get the video to? It won't play. Well, I had a good video here that just shows some of the physiology of how, why. Anyway, my point I'm making is I do believe that there's some benefit to using robotic and navigation systems. You could potentially avoid some of the physiologic, detriments that I showed. Now, last couple things I'll cover on the hip side, right? Navigation adoption has been pretty anemic in the hip, and you could ask why that is. In terms of the landscape, again, similar to the knee, most of the same players have developed systems. And again, we could argue philosophically why it is that hip navigation hasn't taken off. I think a lot of it is because hips do pretty well to begin with, and there's been this view from surgeons that navigation is not going to make me much better. And I think the marketing opportunity has not been that compelling in hips, maybe because direct anterior hips have been so big for so long. Those are some of the reasons, right? But anyway, again, some of the same companies, Ortho-Align, Stryker, Smith & Nephew, they've been the main competitors. So, and again, I think in hips, as far as some of the trends, I mean, the same thing is going to happen. Hips are also moving to the ASC. So the same themes that I espouse for what we'll call it for knee navigation, I think will be relevant for hips as well. So let me just flip through the last couple of, I think the other thing on the hip side that I think the data is now starting to show, when you do navigate a hip, and the data is pretty, especially for my first bullet point up there, it is pretty clear that dislocation rates go down when you get the cup in the perfect position, right? So, I think, again, similar to the knee, there are some clinical benefits to be had. Of course, lately, this whole concept of the hip, spine, pelvis relationship has become very interesting for surgeons. And so, again, you could argue that navigating hips in those environments is beneficial. So those are really sort of the main themes. I know I jumped around a little bit, but hopefully that was kind of a helpful tour of the space and how we think about it. So thanks.
Thank you. Thank you for putting that together. I have questions, but if anybody has any questions, please feel free to raise your hand and we will get you a mic. So you mapped out, Sharat, all sorts of benefits, I guess, and some of the downfalls. Based on your experience, how do the positive and negatives really balance out with this technology? And maybe which technologies do you think are going to be the ones that will ultimately be adopted the most in the future?
Yeah, so first question, the positives and negatives. Again, I'm kind of giving it from a surgeon's perspective. There are obviously multiple perspectives you could look at that, right? But in terms of, let's start with the negatives. It adds time. The biggest gripe that surgeons have is that, putting the instruments on the knee, putting the trackers and things, it adds time. It adds turnover time, right? You've got to clean the robot, you've got to move it out of the room, push it back in, and even the navigation system. It's also cumbersome from a space standpoint, right? In a normal, in an OR, you've already got the back table with instruments and implants and things. You got the sales rep and the circulating nurse. Well, now you add these 5 or 6 additional elements. It sort of creates crowding in the operating room, right? And then, of course, the last thing is the expense. It adds expense, and it's unclear what the benefits. Now, the pros, if you talk about the pros, I kind of went over those, and I'll sort of reiterate them. I think, number one, there is a potential that for maybe lower and medium volume surgeons who don't do 200 knees a year and maybe don't have a fellowship training, which is a lot of the market, as I showed you, the data does show there's a potential for them to have a more consistent outcome. I think that's good. Now, it's hard to prove because a lot of the clinical research is done at large academic centers with surgeons who are, experts. We need to do that research in the community to understand, right, what is the effect at a hospital that does 20 knees? Can they improve their outcomes? Number one. Number two, so I think the clinical benefits could be there. Number two, I talked about kind of the cognitive burden reduction for surgeons. Again, the volumes we're doing now, right, 20 years ago, 30 years ago, my mentors, they did 4 joints a week. Now we do 4 joints by the time Oprah Winfrey show is over in the morning. We're doing, we're cranking through. I don't care what anybody tells you, that is tiring, mentally tiring, right? And so I think it can help lower the cognitive burden where the surgeon becomes a bit more of a technician and not as much a constant decision maker, right? Because the decisions are already made because you've done the CAT scan, you've got the plan, and you're just literally kind of pushing buttons. And that may commoditize our service a little bit, but so I think that's number two. And then, of course, I think the benefits are on the marketing side. It is very clear, right, that the addition of these robots does help hospitals attract patients. It helps them attract patients away from other towns and cities. So those are sort of my thoughts around sort of the pros and cons. You asked the second question, what system will quote unquote eventually be, I guess you're asking maybe the standard of care. And that's tough, right? Because again, in different countries outside of America, robotic adoption has been pretty anemic, right? Because most health systems, they can't afford to spend $1 million, not even close, right? In most of Europe, right? So I think what's going to end up happening, and the data shows this, there will be a lot of segmentation of different customers, different countries, different care environments. Again, even the ASC, right? In an ASC, a large console system doesn't make a ton of sense, So I don't think there will be sort of one standard of care. The market's pretty big. It's getting bigger, right? I mean, the number of patients that need joint replacements in the hip, knee, shoulder, ankle are growing. So I think there will be there won't be one solution because I think the market is that diverse. So hopefully that answers your question.
Yeah. Thank you. You both commented on Mike's slide from Jeffrey Martha at Medtronic, and I'm just curious to get both of your opinions on, what does enabling technology mean for the small companies, which there are thousands of in the orthopedic industry. Do you want to take that first?
Sure. I think, like Sharat said, robotics certainly has a place. I don't think it is in every OR, in every hospital. And I think where small companies are number one, they're the primary innovators of these technologies. It's not typically these days the largest companies developing and then commercializing these. So number one, primarily innovators. But number two, I think as we see the ASC numbers go up, and that's happening rapidly, I think technologies like augmented reality and virtual reality that are cost effective, that add something to the procedure, but don't add that time piece, that maybe don't have that really steep learning curve, that would be more on the bottom right of that graph you showed. I think technologies like that are going to drive adoption, but I also think, we talked about it at the keynote, the relative insanity of asking a patient, post-surgery to drive all the way back and be seen again. I think monitoring and engagement software and apps, even though they're not as compelling as robotics maybe, I think those are going to be the meat and potatoes things that drive technology adoption in orthopedics.
But that's one play. Here's the interesting thing. So my mom is 68, right? And she has a lot of friends who are getting knee replacement. I think a lot of us are probably in that generation. Okay. What I find fascinating is you said something very interesting. You said compelling, right? I'd love to understand what it is about the word robot that is compelling, right? And there's been market research on this of asking patients when they hear the word surgical robot, do they envision that they get kind of clamped down to some table and there's this thing pushing little probes into them, or do they think it's like a surgeon enabler? I do tend to think that some of this, call it what you're calling continuum of care, like wearables or whatever.
Sure.
When I worked at Apple, when we did some patient research, that was equally as the idea of using an Apple Watch to monitor your recovery. Even those 4 words were pretty compelling. I just don't think there's been a unified. The word robotics has been so unified, so there's been so much blast of that word. It's ubiquitous, right? And I tend to think that patients sometimes they echo back what they're hearing, and so I tend to think there's an element of maybe where things could be compelling if the marketing thrust is there and it's sort of consistent. I don't know. That was an interesting statement you made about the word.
And I think even outside of healthcare, maybe robotics is a loaded word. We attribute a lot to it that maybe actual robotics in the real world don't have today. But I think maybe a lot of patients carry those ideas over when they hear orthopedic robots.
Because by strict definition, right, if you look in Webster's dictionary, what we're doing is not actually, like an autonomous, right? It's sort of a haptic assisted, whatever. It's an assisted device. But again, that word, robotics is so interesting. And again, what I find fascinating, and I think about this a lot, navigation software. It's been around for 30 years, but what was it about sort of take the navigation, you add it to this cutting device that made it explode? It's really a pretty subtle but fascinating thing that has happened,
I agree.
So you work for what I would say is a medium-sized company, plus you're also the president of a startup, essentially.
Yeah.
So what role do you see from coming from those perspectives that enabling technology can play, within the portfolio of these medium and small companies?
I've been thinking about that a lot, and I do think this for early stage, or let's just say companies that want to grow in market share, right? I absolutely think that if you can develop a technology that is super user-friendly and makes the surgery easy, lowers the cognitive burden, that can help you grow, because again, what you're doing is you're offering and even especially if it's like a complicated operation. Let's take an example of like a partial knee replacement, right? What we call a unicompartmental knee. You guys are probably familiar with that, right? So it's a part where you just do half the knee. Anytime you're trying to spare the bony anatomy, paradoxically, the operation is much harder to do, right? Doing a keyhole surgery is harder than making a huge incision, right? So what I'm trying to say here is, as a small and medium-sized startup, we think a lot about, as we're going to launch our technology, this may be different from 40 years ago, what can I put around the surgery to make it so that the learning curve for my new customers is much easier? And so again, to me, that includes a confluence of some of the custom cutting guides that are, PSI based. Some of the, it's going to be, it's not just one solution. It's sort of a confluence of custom cutting guides, plus maybe a navigation tool, and you kind of hybridize it. That's kind of how I see as, I think unfortunately, trying to apply one platform technology to every operation, I don't think is the answer. And I realize that's capital inefficient, but even doing a shoulder replacement is very different than doing a knee, because why? The patient's sitting up like this. I mean, there's so many differences to each operation, and getting the perfect solution, there's a lot of nuance, and even in cardiac surgery, doing heart surgery with a Da Vinci robot is very different than doing a knee replacement, right? I mean, the surgical field is open, right? And so I think, unfortunately, there's not going to be one solution. But again, I tell you what we think about is primarily, how can I make it as easy as possible for that brand new customer to do, within 2 cases, I want the learning curve to be 2 surgeries, not 20 or not 200, right? And this has been documented a lot about learning curves and the cognitive burden of learning curves. It is stressful, right? I mean, you don't want to be practicing, on your patients, right? You want it to be easy. So I think there's a lot of interesting strategy, and, so sorry to be so long-winded, but it's an interesting question that you asked, for sure, on that topic.
Thanks. And Mike, obviously a lot of companies are thinking about this. Your job is to analyze where the market is going over the next 5 or so years. So just how do you see the enabling technology segment growing as compared to maybe the joint replacement or the spine market?
Yeah, I mean, obviously really high growth, but off a small base, extremely small base compared to any of the other segments in orthopedics. I sort of was chasing my tail a little bit as I created this segment to report on, because I did it at a time when capital sale, you were getting $1 million for a
right.
Mako, pretty consistently. That was a dedicated, forceful revenue stream for companies. But the pandemic comes around, things change, the environment changes a little bit. We saw a pretty quick shift away from these outright sales. So I think the growth is going to slow down.
Yeah.
Certainly double digits, but again, off of an extremely small base. And I think a lot of that revenue, that upside revenue, is still coming into the companies, but on the implant side
right.
now with the pull-through.
Yep. Yeah. I mean, as a business model, right? It's hard to have a business model with recurring revenue and high margins, all the things that matter in a healthy business. And of course, the sales process the sales cycle is so long. I mean, to your point, you asked maybe the existential question: is there a company that can stand alone and sell only enabling technology and become like we haven't seen, I can't, other than Da Vinci, right?
Yeah.
And of course, or intuitive surgical sorry, that's of course in a non-orthopedic space. And there are obviously a lot of factors that are different in doing, obstetrics and gynecology surgery or prostate surgery versus doing, implant surgery, right? So it is an interesting dynamic about, how it'll grow, for sure.
Great. Well, I think the clock is running down here and we are out of time, but thank you
thank
so
you
much
for having
to both of you again for pulling this together, and thank you to everybody for attending today. We appreciate it.
Yeah, we
Hope
appreciate you
have a great
sticking
day.
with us, guys.
Thank you very much. If you have any questions, obviously we can, but thanks again.
Thanks.
Thanks for the opportunity.